Thanks for the invitation. I don't know who's responsible. I had you on the phone. Manon makes the impression that she took the decisions. But it's a real pleasure to be able to talk about a lifetime passion that for some time I've been able to share with Frans. Now, the title I've been assigned is Preparing Pathology for the Molecular Era, and I didn't think about it. I immediately said yes. But when I started to think about it, the issue came up. What does one need to prepare? Pathology. I don't think pathology needs to be prepared for the molecular era. Pathology is as lively, as dynamic, in full evolution in this molecular era. So I don't think pathology needs to be prepared. I do think pathologists need to be prepared, and I will talk about that a little bit. And then there are consequences for disease classification, and I will talk about that a little bit as well. So this is the background. I like Stephen Friend and Leroy Hood's take on medicine in the post-genome era. They think about it in terms of P4 medicine. It is predictive, personalized. I don't like personalized because medicine has always been personalized. Good medical care cannot be other than personalized. But then Hans will give further details on his take on personalized. Preventive, with knowledge of genetic traits responsible for higher risk for certain diseases, that is becoming a reality. And participatory, patients have much more information now and can be much more active in the interaction with the medical profession. And for pathologists, this has serious implications because it requires diagnostic, prognostic, predictive, and response biomarkers. Because what do clinicians need from pathology, or as a response from a pathologist working on one of their cases? If we think about it in terms of a patient cohort, for example, a series of patients with colorectal cancer, the blue part in the pie chart are those that will have the primary surgical intervention, and they will not recur. That's about half of a cohort of colorectal cancer patients. But then the other half, the disease will go on. And this represents those that will recur, but will not respond to the adjuvant therapy that is given to those of which the likelihood that they will recur is relatively high. But not everybody that's subject to adjuvant therapy will respond to the adjuvant therapy. You would like to spare those patients the adjuvant therapy with its side effects. And then even those that initially respond, part of those will recur eventually, and the clinician would like to know which patients are likely to respond to the second line, nowadays mostly targeted treatment. And all that requires from the pathologist to begin with a classifying diagnosis, and for that diagnostic biomarkers are in use. And towards the end I will indicate the importance Frans has had in developing diagnostic biomarkers. It requires information on prognosis, disease extent through the TNM classification, but beyond that, the likelihood of recurrence through prognostic biomarkers, the likelihood of response to therapy, predictive biomarkers that will tell the clinician which molecular events in the tumor are potentially druggable, and then residual recurrent disease along the line can residual disease be detected, and can recurrent disease detected early on also through biomarkers. Now, it is often proclaimed that prognostic and predictive medicine is something new, and I'd just like to show you an old case done with old-fashioned approaches, just to indicate that medicine and pathology has always been prognostic and predictive to some extent. This is a male patient, 62 years old, recurrent coughing, lately with some blood in the sputum, weight loss, dizzy spells, and on the chest x-ray, a parahilar lesion in the right lung of 5 centimeters, and the MRI indicates a suspicion of brain metastases. The pulmonary physician performs a bronchoscopy, finds a bulging lesion in the right stem bronchus, does brush cytology in the biopsy, and this is what the pathologist sees. Even a non-pathologist may be able to make a diagnosis on this. The left panel, the right panel, is the cytology, a naked nuclei with a very coarse chromatin. The nuclei are about 2 to 3 times the size of a red blood cell. The nuclei mold together, and for an experienced cytologist, and even for a non-experienced cytologist like me, it's relatively simple to make a diagnosis of small cell carcinoma. And this is confirmed by the histology. There's necrosis, an extensive crush artifact. Artifacts can be telling, and the diagnosis is rapidly made. With the knowledge that there is the likelihood of brain metastases, it qualifies as extensive disease. And what does this mean? It means that the patient has a 5% chance of 5-year survival, which is prognostic information. It indicates that surgery will have no effect on survival, which is predictive information. And it indicates that the patient has a 70% likelihood of response to chemotherapy, which is also predictive. So the conclusion I want to communicate to you is that histopathological diagnosis, as such, has always conveyed prognostic and predictive information. But what we now have in the molecular era is more tools to extract prognostic and predictive information from cell and tissue specimens. Now, what we do as pathologists is classify disease, and an important notion, it's pretty obvious, is that a classification should be rooted in biology. The way the Royal College of Pathologists of the UK talks about this is pathology is about understanding disease, and it's the science behind the cure. Because using this understanding of disease to provide the clinicians with relevant diagnostic, prognostic, and predictive information, allowing them to make reasoned choices regarding treatment options. One can turn this upside down to state that disease classification not based upon understanding the pathophysiology of the condition are prone to create confusion and fruitless debate. And I can tell you fruitless debates we have in pathology. But fortunately, such classifications tend to be short-lived. Now that's maybe a bold statement. Let's look together at something that's been close to my heart for a lifetime. The way it comes through in the current WHO classification, which dates from 2010, the classification of carcinomas of the colorectum. In the left panel, in the right panel, you see some of the images that go along with some of the diagnostic terms over here. This is a medullary carcinoma. It is solid, and it shows infiltration with lymphocytes. This is a mucinous adenocarcinoma. This is a sigmoid cell carcinoma. These are purely morphological terms. In 2010, and I was one of the main responsibles for doing this, in 2010, we still couldn't get any further than morphological indicators to subclassify colorectal cancer. Obviously, we in daily practice go a little bit beyond that, because the TNM classification conveys important prognostic information. You see here a slice of colon cancer where the cancer does not invade the muscularis propria of the bowel wall, and so it's a T1. And here, the muscular layer has completely disappeared, and so it qualifies as either a T3 if it is not on the serosa yet, or as a T4 if it's on the serosa. And then the other important parameter is the N, are there lymph node metastases or not? And TNM remains a backbone of the staging of colorectal cancer. But the question is TNM stage good enough? And if we look at we see the stage groups here, taken together from the T's, the N's, and the M's. The most positive stage 1, the prognosis at 5 years can be even higher than 90%, maybe 95%. Pretty good. The issue is that there's still 5% of patients that will recur. And the question is, can we identify those? And the same reasoning goes for stage 2 and stage 3. These percentages are rather approximately. And notably the clinicians will want to know who's who. And so the conclusion has to be that TNM stage is not good enough. Now, pathologists have been very creative, and they have come up with ranges of, and some of them pretty popular. There's not a diagnosis of colon cancer that goes out without, this is well differentiated, this is maybe a moderately differentiated, some might call it a poorly differentiated. What gains in popularity and status is budding as a reflection of invasive activity of the tumor, and vascular invasion, because that's associated with the likelihood of, if it's a lymph vessel, lymphatic metastasis, or if it's a blood vessel with hematogenous metastasis. And the question arises, are these parameters prognostic or predictive? And some of them are. Some histological subtypes have a limited relationship with molecular characteristics. I indicated the medullary, the mucinous morphotypes. They are often found in the right colon, and they are relatively specific for colon cancers that are deficient in mismatch repair or microsatellite unstable, if you wish. And this is prognostic and predictive information. I'll show you how it impacts on prognosis. On the other hand, what has become very popular in the analysis of colon cancer, KRAS and NRAS mutation status, is not reflected at all. There's no way that looking at a H&E stained section, the pathologist can say in which category of RAS status the case will fall. The host immune response has gained importance. I just indicated that in the medullary morphotype, the immune response is usually quite vigorous. The immune response is reflected in what's nowadays called an immunoscore, and the MSI, microsatellite unstable cases, usually have a high immunoscore, so that's proven to be a useful parameter. But grade is poorly reproducible and of limited value. Vascular invasion is prognostic but not predictive. And the same holds true for budding, prognostic but not predictive. And that is why molecular testing has become mainstream in the diagnostic workup of colon cancer. And this is just a simple example. This has been us for 10 to 15 years now, mismatch repair deficient colorectal cancer, which is relatively easy to detect because it can be done using immunohistochemistry with a panel of antibodies against the 4 most important proteins involved in mismatch repair. And in panel A, you can see the absence of nuclear staining for MLH1. That usually goes along with absence of nuclear staining for PMS2, but the other two, MSH2 and MSH6, show normal expression. The conclusion must be that there is either through methylation of the promoter of the MLH1 gene or through a mutation in MLH1, absence of expression of MLH1, and this case is mismatch repair deficient or microsatellite high. And this can also be done with relatively simple tests on which I will not dwell. We've looked at a large series of about 1,500 colorectal cancer cases in the context of a clinical trial. And this is just to show you that the stage 2 and 3 patients classified by MSI status, the MSI high, the red ones, do much better, confirming the prognostic information that the MSI status carries. And this is the other molecular test that has become very important for the workup of colorectal cancer, the determination of the KRAS mutation status. And the principle is pretty simple, because the EGFR therapy interferes with dimerization of the EGF receptor upon binding to its ligand, and hence downstream signaling will not occur. But then if there is in either one of the pathways downstream of the EGF receptor a mutation that constitutively activates the signaling pathway, it does make sense to block upstream of that molecular event. And so KRAS mutated patients do not respond to anti-EGF treatment, EGFR treatment, and that's the reason why KRAS mutation status has become a must for each and every pathology department. That is all done on formalin-fixed paraffin-embedded tissues. And over time, we have learned that there's almost nothing you cannot do with formalin-fixed paraffin-embedded tissue. This is what it looks like. A paraffin block with a chunk of tissue in there. You can cut a section and stain this with hematoxylin eosin. You can cut the section and send it to the molecular pathology laboratory for further analysis. The analysis can cover a wide range of molecular directions. It could be genomic DNA, messenger RNA, microRNA. It can be proteins. MALDI imaging, a combination of imaging through digitizing of a slide, and mass spectrometry has gained some popularity because it provides molecular information along with morphological information. I'll talk a little bit about what we did with expression profiling, array CGH to look at copy number variations, all sorts of sequencing modalities. All of that is possible using formalin-fixed paraffin-embedded tissue. And then what's been added recently is the digital microscopy, and that can be on an H&E section, but it can also be advanced molecular imaging. And we'll talk about that in a second. We can do these things not only on the primary tumor tissue, as you just showed, but what has gained some popularity is doing analyses on circulating tumor DNA or on circulating tumor cells. And then that depends a little bit on the tumor type, but it gains in importance to also include metastatic tissue in the workup of a patient that has recurrent disease, because tumor heterogeneity may result in a molecular status, mutation status of metastatic tissue that does not completely correspond to the status of the primary tumor. And all of that has bearings on prognosis and prediction of response to therapy, or following up the patient in terms of the risk of recurrence. And this is the list of the things we can look for under histopathology, the characteristic elements. Site is important in colon cancer. The colon cancers in the left are not the same as colon cancers in the right. Extension, we just talked about the TNM, so that remains an important backbone. Conventional histology. And then a whole bunch of things we can do on section-based approaches, immunohistochemistry, in situ hybridization, to look at either copy numbers, for example, or at levels of expression of messengers. I'll, in red, some issues I will discuss a little bit further. Highly multiplexed cellular molecular imaging. And what's coming up strongly is image analysis on digital slides through convolutional neural networks, popularly called deep learning. And in the molecular panel, a continuously growing array of possibilities of molecular workup of tissue and cell samples. What we've done a few years ago, this dates from a publication in 2013, was to use expression analysis. This was with the methodology that was popular in those days, microarray. And based on the 1,500 patients that I just talked about and unsupervised clustering, it was possible to separate colon cancer into 5 different subgroups. The subgroups are indicated here. These are the genes or the gene packages that were involved. And in this panel here, the correlation of the subgroups with the behavior, and notably when we look at survival after relapse, a distinct separation, which is not of clinical significance so much as to indicate that the expression arrays-based subtypes do correlate with biological behavior. Now, we were not alone, because in the same year, there were 6 papers with the same, but not exactly the same, results. All of them claiming that based on expression analysis you could make subtypes, but if we looked at the commonalities and the differences, it was clear that they were not identical. And so what do you do with so many different approaches? And this was facilitated by Stephen Friend's SAGE organization. The 6 groups that published these data got together and pooled the data. Strong involvement of competent bioinformaticians, or in silico biologists, as my favorite bioinformatician tends to call himself. And what they came up with after rounds of working through the data and a lot of discussion is the consensus molecular subtypes of colorectal cancer. And this is from a paper published in Nature Medicine in 2015. 4 subtypes with a slightly different distribution in the colon: the MSI immune, the canonical, the metabolic, and the mesenchymal subtype, with differences in prognosis and with differences in terms of the molecular pathways involved. one could think that this contrasts with the TCGA data, because that's genomic data. But this slide I put in just to show that, by and large, the CSM1 subtype, the MSI immune, corresponds to the hypermutated in the TCGA, and that the additional information is pertinent to the large category of the chromosomal instability subtype according to the TCGA, because that could be broken down into the canonical, metabolic, and mesenchymal subtypes. And the same question could be asked relative to the consensus molecular subtypes. Does this subtyping convey important biological messages? And what emerges almost constantly is subtype 4, the mesenchymal subtype, that carries a much worse prognosis. And the kind of thing you hope might happen is that the CSM subtypes might be helpful in identifying actionable targets. And to some extent that is true. I've put between brackets the drugs that have been considered, have been studied, or are under consideration for use in this context, and some clinical trials are in the pipeline or already conducted based on stratification using the CSM approach. Back to tissue, multiplexed immunohistochemical imaging of the immune response in colorectal cancer. That has gained an enormous amount of traction in recent years with the immunotherapy revolution that is reshaping the approach to treatment of cancer. And also in colorectal cancer that has resulted in significant new findings. The way we originally went about it, this is on the same series of 1,500 patients that I talked about. You can make tissue microarrays. And then the old-fashioned way to do this was to cut serial sections, use one antibody per slide to stain the sections. And then the new thing, that's why I dare call this multiplex anyway, is because you can digitize these images, stack them, and ask the image analysis system to compile an image that gives you not only the relative proportions of the different cell types, but also the proximity of cell types relative to each other or relative to the tumor tissue. And this is kind of a poor man's approach. It's become much more sophisticated recently. This is just to indicate that multivariable analysis of the prognostic value of conventional molecular and the host immune response parameters in colorectal cancer indicate something that was already published in 2006 by Jérôme Gallon in a landmark paper, when he stated that the immunoscore, the intensity of the presence of notably CDH positive T cells is of much more significant prognostic value as MSI, and in this data we came up with the same result. In the last 5 years or so, this has become much more sophisticated. I took this image from the Perkin and Elmer website. I don't have any stock in Perkin and Elmer, so I didn't have to put on the slide with my CEO eyes. Because this is multiplex immunofluorescence imaging. You can do the same thing using a panel of antibodies with different fluorochrome markers. What you can recognize here is the cancer cells stained by cytokeratins. It used to be one of Franz's favorites. Immunocytes of all different types labeled with different fluorochromes. And so this is a quantum jump in efficiency, and also with the image analysis systems available now, the notion of where components are relative to each other to provide a deeper understanding of the interaction between different cell populations. And this has become even more sophisticated. The problem with fluorochromes is that the emission spectra of fluorochromes overlap. And so the computer system will have to go through a fairly complex deconvolution calculations in order to come up with clear pictures. Whereas if you label the antibodies with elemental isotopes, of which the spectra in SIMS are much better separated, this can result in a much higher level of multiplexing, so to speak. And in this particular paper, that's the panel with the images, they came up with an approach that allows simultaneous detection of 32 different antigens in tissue sections in the context of also recognizable tissue structure. So biomarker identification has become a very sophisticated game, so to speak, but highly promising, and with this type of approach, in a much better position to, in the years to come, to provide the information that the clinicians are looking for. And then there's the 21st century pathologist. This pathologist is doing something that many pathologists are already doing. They don't look through a microscope anymore, but they watch the screen because the image has been digitized. But that's, let's say, a superficial way of using the potential of this approach. The use of sophisticated image analysis through deep learning is already coming up with the parameters that, for the time being, they are the parameters that the pathologist can also identify. But the machine does it in a more reproducible way. And who knows, maybe in the future, machine learning will be able to recognize parameters in these digitized slide data that the human eye cannot see. I find it difficult to believe that that will be the case, but we'll see how this pans out. At any rate, decisional support through quantification in the system, through image analysis, I think it will not take over from pathologists. It will make the life of pathologists easier. So if we get back to where we started, pathology in the molecular era, what is changing is that beyond what does it look like, the pathologist now looks at which key molecular mechanisms are involved with prognostic and predictive significance. And just a few examples, ER-PR and HER2-neu in breast cancer, that's an old one that's been around for 20 years, but it's proven the validity of the concept. I talked about KRAS and colon cancer, but it's also important in lung cancer, head and neck cancer, pancreatic cancer. And then the revolution in the treatment of pulmonary cancer with specific treatments for ALK, MET, EGFR, and ROS status. IDH1 and glioblastoma is a relatively new one. And the MSI that has risen to rapid fame once the FDA decided to accredit immune checkpoint therapy to whichever tumor type that was microsatellite unstable. So that it's rapidly becoming a very frequently performed test in the pathology lab. And all of this is assisted by advancing technology for molecular morphology, because almost anything can be done on FFPE. There's fast and cheap next generation sequencing. Some of it is being done on disease and target dedicated analytical platforms. The multiplexed immunophenotyping, I have high hopes that that will pan out nicely. And then digital microscopy with AI support through deep learning. Now, the question arises, how is this going to impact on the classification of disease? And I put next to each other a ratatouille and a Swiss cake. And some think it's going to be a ratatouille because we'll have a mixture of parameters that are, let's say, the parameters at entry level into new forms of classification. I don't think that's going to be the case. My perception is still that it's going to be according to Swiss precision almost, the layered approach, and molecular parameters add a new layer of complexity without completely disturbing what exists. And this is nicely illustrated in the molecular classification of glioblastoma in the new volume of the WSO classification of brain tumors, where you can see that a glioblastoma, anaplastic astrocytoma, the old terms exist, but then they are completed with molecular information. This has some implications for pathology education, because pathology in terms of mechanisms of disease, the role of diagnostic pathology in quality medical care is essential in undergraduate medical curricula. And pathologists and those responsible for medical curricula should take this seriously. What is of burning importance is redefining postgraduate training program content in pathology, because the present emphasis on classical morphology needs to shift to concepts, understanding disease, the science behind the cure. Pathologists need to be trained in molecular mechanisms and methods, and they need to relate better to bioinformaticians. 1 minute.
That's okay.
Frans was an early pioneer of diagnostic molecular imaging. I dug into your publication list, and these are early papers from Frans. Part of them are published in really good pathology journals, good diagnostic pathology journals. And for someone that wrote a PhD in biochemistry and was a fresh newcomer in the pathology department, that was quite something. And this cannot be, the importance of this cannot be overstated. And we have to be thankful to Frans for this. When I recently redid my library, I found the book that you gave me when I left Maastricht in 1989. And that's what you wrote in your characteristic handwriting. And I need to set the record straight. I was convinced that you would be important for Maastricht in general, but for Maastricht cell biology and for GROW in particular. And that panned out. You thanked me for what I contributed to cell biology. I didn't contribute anything to cell biology. But the other way around, with you, diagnostic molecular imaging started in the Netherlands. And I'd like to thank you for your essential contribution to the development of molecular pathology, for your dedication to GROW, which is very close to my heart because I was one of the initiators of groei and differentiatie, as it was called in the beginning, and also for your friendship. Thank you very much.